members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Chetan Damne, Chief Guest Dr. Vinay Bohara, all discussants and participants to this virtual symposium on challenges and opportunities in the management of pediatric AML. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit is a very passionate and dynamic hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Madan. Well, very good morning to all of you. Today, our guest speaker for the day is Professor Chetan Damne from Mumbai. And he's going to lecture us on challenges and opportunities in the management of pediatric acute myeloid leukemia. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our Chief Guest for the day, Dr. Vinay Bohra from Indore, our guest speaker for the day, Dr. Chetan Damne from Mumbai, all our discussants who are themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning. Let me introduce our weekend activities for the next weekend. Next Saturday, that is 23rd September 2023 from 7 p.m. Indian Standard Time onwards, we have a webinar on MDS, an updated approach to diagnosis and treatment by Dr. Aditi Shastri from Bronx, New York. And the following day, that is Sunday, 24th September 2023, from 11:30 a.m. IST onwards, we have a webinar on luspatercept therapy in thalassemia and update by our guest speaker, Dr. Maria Domenica Capellini from Milan, Italy. Let me introduce our discussants for the day, and we have a galaxy of them. To start with, we have Dr. Amit Galgali from HCG Bengaluru, Dr. Anand Kesi from Sri Shankara Cancer Hospital and Research Center, Bengaluru, Dr. Balaji TK from Cancer Institute, Adyar, Dr. Gnana Mani S from CMC, Vellore, Dr. Juhi Shah from Fortis Hospital, Mumbai, Dr. L. Ajitha from GK&M Hospital, Coimbatore, Dr. Megha Saroha from ESI Medical College and Hospital, Faridabad, Dr. Pritam Singha Roy from Medica Super Specialty Hospital, Kolkata, Dr. Purvi Kadakia Kuti from LTMG Hospital, Sain, Mumbai, Dr. Rajat Bhattacharya from Apollo Multispecialty Hospital, Kolkata, Dr. Ruchi Ojila from BMC, Raipur, Dr. Satya Prakash Yadav from Medanta, the Medicity, Gurugram, Dr. Shivani Patel from Choithram Hospital and Research Center, Indore, Dr. Silki Jain from Max Hospital, Delhi, Dr. Shrikant Marda from Ankur Hospital, Hyderabad, Dr. Srinivasan from PGI, Chandigarh, Dr. Sujata Sharma from Lokmanya Tilak Municipal Medical College and Hospital, Sain, Mumbai, Dr. Sunil Jondale from AIMS, Raipur, Chhattisgarh, Dr. Sunil Udgire from Sparsh Hospital, Bengaluru, Dr. Vandana Bhardwaj from St. John's Medical College, Bengaluru, and Dr. Vinay MV from Manipal Hospitals, Bengaluru. Now it's a time to introduce our special guest for the day. We have with us Dr. Vinay Bohra, who is a very dynamic hematologist from Indore. Dr. Vinay Bohra has done his DM in clinical hematology, working as a clinical hematologist at CHL CBCC Cancer Center, Indore. He is a Canadian fellowship trained hematologist and bone marrow transplant physician specializing in adult and pediatric hematology. He has trained and worked at various institutes of repute, such as Apollo Hospitals, Ahmedabad, Vancouver General Hospital, Vancouver, Canada, Institute of Hematology and Transfusion Medicine, Kolkata, and ZGS Medical College and KM Hospital. Currently, his areas of interest are clinical hematology, thalassemia, autologous and allogeneic transplants, and other short and long-term issues related to transplants. Interestingly, laboratory hematology, its correlation to clinical hematology, and research publications are also significant portions of his work. It's my privilege to invite him to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Vinay Bohra.
Good morning, everyone. Thank you, Amit Bhai, for this kind introduction. And of course, thank you, MHG. Thank you, MB Agarwal, sir, for this honor. It's a matter of, proud privilege for me to be here in this capacity. So, as a hematologist practicing in Tier 2 city of Indore, I get this opportunity to manage adult as well as pediatric patients who come to me with different benign and malignant hematological disorders. Because I think most of us who are here would agree that right now in Tier 2 and Tier 3 cities, we don't have there is a lot of overlap between people who practice adult as well as pediatric hematology. But then everyone who does that would agree that treating patients with pediatric hematological disorders is highly rewarding and highly satisfying as compared to their adult counterparts, simply because they during the treatment they have probably lesser side effects and they've got better outcomes. So it is highly rewarding to see pediatric patients whom you have treated, a decade ago, and then now they are grown up as adults and adolescents doing well in their life. At the same time, last 2 decades, we've got significant, development in supportive care. We've got better antibiotics, antifungals, and that has made our lives easier when we treat these patients with highly intensive chemotherapies. To add to this, we have almost entered into a golden era where we have immunotherapies, and now we have got trials of our own CAR T cell therapies going on in our own institutes of excellence. So with so much of with our we have at our back end and so much to explore, it would be really interesting to listen to and to learn from Dr. Chetan about his views and insights into pediatric AMLs. And with this, I would hand this over to Dr. Quran. Thank you.
Thank you, Dr. Vinay Bohra, for that great words of wisdom. It means a lot to us. And thank you for accepting our honor as a chief guest for the day today. Thank you so much for being with us today. Let me share the screen again. Now it's a time to introduce our guest speaker for the day, Professor Chetan Damne from Mumbai. Dr. Chetan Damne is professor at Pediatric Oncology Department at Tata Memorial Hospital, Mumbai. His educational details include: he is currently working as a professor at Department of Medical Oncology at Tata Memorial Hospital, Mumbai. He worked as a pediatric MD. He did his MD Pediatric Oncology from MD Anderson Cancer Center, Houston, Texas, USA in the year 2011. MD Pediatric from Cook County Hospital, Chicago in the year 2008. MSc Molecular Biology from Penn State University, Hershey, USA in the year 2005. MBBS from Mahatma Gandhi Institute of Medical Sciences in the year 2001. To brief his professional career, he worked as a senior registrar from National University Hospital, Singapore in the year 2012 to 2014, associate consultant and assistant professor at National University Hospital, Singapore in the year 2014 to 2017, consultant and assistant professor at National University Hospital, Singapore in the year 2017 to 2018, assistant professor at Tata Memorial Hospital, Mumbai in the year 2018 to 2020, associate professor at Tata Memorial Hospital, Mumbai, the year 2021 to 2023, and from 2023 onwards, he is working as a professor at Tata Memorial Hospital, Mumbai. To name his honors and awards, he has received Integrative Biosciences Fellowship, Penn State University, Hershey in the year 2002, Fellowship for Advanced Studies in Pediatric Oncology at MD Anderson Cancer Center in the year 2011, National Cancer Institute of Singapore Clinical Trial Workshop Award for Pilot Study of Expanded Activated NK Cells with anti-GD2 for Neuroblastoma in the year 2016. Exxon Mobil Fellowship, National University Hospital, Singapore in the year 2017. ICMR grant for studying the safety and efficacy of cytokine activated memory like NK cells in AML. intramural grant for generation of cytokine-induced memory like NK cells for AML. His publications include 3 book chapters as well as 23 research papers and reports. He also has an experience in working on the development of cell-based therapies, worked on expanding T regulatory cells on artificial antigen-presenting cells for graft versus host disease, published in abstract format. He is also involved in various clinical trials as principal investigator or co-investigator in NCT 0124095676, NCT 02123868, and NCT 0324424603 trials, all involving cellular therapeutics, specifically NK cells expanded and activated alone or in combination with tumor-specific antibodies. Today, he is going to lecture us on challenges and opportunities in the management of pediatric acute myeloid leukemia. Well, thank you so much. Over to you, Professor Dr. Chetan Damne.
Thank you so much. I thank the entire team from Mumbai Hematology Group for giving me this opportunity to talk to you. And thanks for the generous introduction. I am just trying to get the Zoom working. So I'm transferring my data from one computer to the other. So just bear with me for 2 minutes. In the meantime, if somebody wants to say something on AML in pediatrics, please go ahead. Just give me 2 minutes.
No problem, sir.
Just 1 minute. I got it. Give me 1 second.
Sure, no problem. Take your own time.
Yeah, can you see my screen? Am I audible?
Yes, you are very much audible. Please go ahead.
Yeah. So good morning, everyone. Today I'm going to present some of the challenges and opportunities that we face in pediatric AML, and we will try to give it an Indian context. Okay, so if you see here, this is just a distribution of AML in the population, and you see that AML is not a pediatric disease to begin with. It's an adult disease. Okay, so if you see the incidence of AML in pediatrics, it is about 18.2 per million in less than 1 year olds, 10.4 in about 1 to 4 year olds, so on and so forth. But basically, as the age increases, the incidence goes down until 10 to 14 years of age, and then after 15 years of age, the incidence of AML increases, and above 60, there's a rapid increase in the incidence of AML. So it is not a pediatric disease to begin with. In general, if you see from the WHO data, around 700 new cases of AML will be diagnosed in US every year. In India, we don't have a good number, exact number, but there's an estimate from the WHO and the Globocon where they felt that there are around 11,850 new cases of leukemia that were seen in the year 2020. And based on estimate that 50% of those acute leukemias will be ALL, there'll be around 1,750 cases of AML per year in India. So this was based on there is another study by Dr. Sham, who has at TMH, who has studied around 1,200 cases over a 10-year period in India. So basically, what we want to show here is that around 1,750 cases of AML are seen in India every year, of which the number of cases that are reported in literature is just 1,200 over a 10-year period. So we are not even reporting the number of cases that we see. And why is that so? Because all of them are not treated uniformly, and they are not. We are not in the habit of publishing our data. So definitely, there is a gap where we do not acknowledge that we are not. We have a significant challenge in treating AML, and we need to accept that gap or identify that gap once we start publishing our data, or once we form a registry to really find out what are the challenges we face, and the number of cases we see, and the number of patients we are actually able to treat. So that is a major point that I would like to highlight, as mentioned in the introduction. So now, if you see, we are trying to improve outcomes of AML across the globe. And in contrast to what we have done in ALL, the outcomes of pediatric AML have been static for a long period of time. So anywhere between, we are able to give an event-free survival of 50 to 60% maximum. Actually, if you consider the trials that have been published in the recent past, 55 57% is the maximum in the NOFO AML 2004 trial. The overall survival increases because of the transplant that we are able to do for these patients in CR1. So how do we improve outcomes? As I said, in the ALL story, we have been able to improve outcomes from 20% to now over 80% in most of the patients with ALL across the globe, including India. But how did we achieve that? We achieved that not by introducing a lot of new drugs. We just learned how to use our drugs wisely. And that is how we are able to improve the outcome of AML. So what do we have in AML? In AML, we have a 7+3 regimen that was introduced in 1973 by Dr. Yates in 1973. And this was from the Roosevelt Park Hospital. And what they found out was they were able to achieve remission in adults in about 63% of the patients. Okay. And this year is 2023, and this is the golden jubilee year of 7+3 regimen. And if you see, we are still stuck to the 7+3 regimen, though we have tried to improvise upon it over a long period of time. So what have we done? We have tried to dabble with the anthracycline that we use. The 7+3 regimen has daunorubicin, but we have tried to use different anthracyclines. And this is the data from pediatrics, where you have seen that in the MRC 12 trial, there was slightly better outcome for mitoxantrone as compared to daunorubicin. And here is from the adult data, where daunorubicin versus mitoxantrone versus idarubicin in adults did not show a major difference. So the choice of anthracycline is now dependent on the group that is using it. So the COG will use anthracycline that they prefer, which is daunorubicin. The UK MRC prefers idarubicin, so on and so forth. So that is why we have seen that the choice of anthracycline has not changed over a period of time, and the difference in anthracycline, the different anthracyclines have not made a difference in how you improve outcomes or to improve outcomes. Then what else can we do? We can increase the dose. So that has been done in several trials. And this is the trial that was published in NEJM in 2009, where what they did was they compared 45 milligram per meter square of daunorubicin versus 90 milligram per meter square. And in that, they found that the 90 milligram per meter square definitely did better. But 45 milligram is not what we use. We use 60 milligram per meter square. And this is data from Alan Burnett that was published in Blood 2015. And they used compared 60 versus 90 milligram per meter square of daunorubicin, and the outcomes have not changed. So the question is, how can you do a little more better? So double donor trial, this is again in adults, but most of our data that we use in pediatrics is from the adult trials. So what they did was, they did a very smart thing. They did randomization. The R1 randomization was between 60 milligram versus 90 milligram of daunorubicin. And after 218 patients, they saw that there was no difference in the dauno between 60 and 90. So the 3-year relapse-free survival over a long period of time was basically 53% versus 90% in the dauno 60 versus dauno 90. And the overall survival also was very similar. So there was no difference. In fact, the dauno 90 had slightly lower overall survival as compared to dauno 60. So that means you're adding a lot of toxicity for these patients. So what they actually did was, when they enrolled the first 218 patients, they saw that the outcome of end of induction 1 was not different. So addition of 90 milligram as opposed to 60 milligram did not make a difference. So they closed that randomization, and then they randomized the patients to receive a single arm of daunorubicin followed by 3 doses of HiDAC versus 2 cycles of daunorubicin versus with 2 HiDAC. So this is called a double donor. So those who received single daunorubicin in their chemotherapy protocols, they had a relapse-free survival of 50%, while the double donor had a relapse-free survival of 60%. But when you compare the overall survival, the single donor arm had an overall survival of 77%, whereas the double donor arm had an overall survival of 75%. So we can say from this trial that 2 versus 1 donor does not make a difference. 60 versus 90 donor does not make a difference. So ultimately, we have gone back to using 60 milligram per meter square of daunorubicin, and the number of cycles would be 1 cycle of daunorubicin. But again, this is from the adult data. Currently, many of the pediatric trials give 2 cycles of induction, which include anthracyclines. Okay, so yeah, so now the question is that in children, can we escalate the doses of anthracyclines? And the answer is yes, but then we have to deal with long-term side effects. In adults, that is not an issue because their overall survival is not that prolonged. And they even if they get a good 5-year event-free survival or overall survival of 5 years is good enough for the adults. But for pediatrics, this anthracyclines will have a definitive effect on the cardiac function of these patients. So if you see the COG trials where they studied the long-term effects of anthracyclines in children, the AML 0531 5-year follow-up showed that 12% of the children had more than grade 2 left ventricular systolic dysfunction. While when they followed it up very closely with every patient being analyzed on the 1031 trial at 3.5 years, they found that 21% of the patients had cardiac side effects, which was in the form of grade 2 left ventricular systolic dysfunction. And if you see the long-term outcomes, the patients who had, here you can see the overall survival and relapse-free survival. So 5-year EFS in the ones who had left ventricular systolic dysfunction was 36%, while who did not have was 50%. So definitely this long-term survival is affected when you give higher dose of daunorubicin. And the same thing is for the overall survival, where if you did not have left ventricular dysfunction, it was 66%, whereas if you develop left ventricular dysfunction, it was 56%. So then, do we have other ways of trying to get the donor in? So CPX351 is a medicine that is a liposomal formulation of fixed dose combination of daunorubicin and cytarabine in a 5:1 ratio. And this was felt that in the adult trials, they felt that this definitely improved the tolerability of daunorubicin. And this is the comparison in the trial published in Lancet 2021, where the CPX531 with a median overall survival of 9.3 months in the adults as compared to 5.9 months. Now in patients who are more than 60 years of age. The 5 years overall survival was definitely significantly different, with 18% for the CPX531 arm versus 8% for the 7+3 arm. So these are the alternate formulations that we might be able to use in the future, but this has to be done in the context of a clinical trial. Now we are done with the anthracyclines. Now we try to see whether we can intensify therapy in another way. So one of the ways to intensify therapy is using bortezomib. So the AML 1031 trial tried using bortezomib, and they found that there was absolutely no difference in event-free survival and overall survival by adding bortezomib. And in fact, there was slightly increased toxicity in the bortezomib arm. So when we analyze these results, we want to look at certain things. We want to look at the event-free survival, overall survival, cumulative incidence of relapse, and the therapy-related mortality or treatment-related mortality. And you see here that the p-values, none of them are significant. So that means statistically there was no difference in the use of bortezomib on the AML 1031 protocol. Now, if we cannot do anything with the anthracyclines, can we do something with the cytarabine? So what the St. Jude trial did was, in AML 02 trial, they use cytarabine at 100 milligram per meter square for 10 days, which we generally use, versus 3 gram per meter square on day 135. So they used higher dose of cytarabine and wanted to see whether at the end of induction, more people, more children are able to achieve a MRD-free remission and MRD negative remission. The dose of daunorubicin was 50 milligram per meter square and etoposide was 100 milligram per meter square. So did it matter? So again here, there was no difference. So this is the high dose group versus the low dose group. And here again, if you see the p-values, none of them are significant. There was a slight increase in the fungal infections that was seen in the high dose group, where patients who received high dose cytarabine had an increased risk of fungal infections. So again, intensifying treatment is not helping us here. Again, when we saw that we added etoposide, we used higher cytarabine, that did not help. When we added bortezomib, it did not help. So etoposide is something that some of the protocols have really stuck to. But from the UK MRC trial, as well as the our own trial from India, we have seen that the DA versus AD, there was again no difference. So the composite complete remission rates was 82% versus 79% after second induction. The induction deaths was 17% in both arms. The 5-year EFS was 34% in both arms, and the overall survival was 44% versus 42%. So again, what we see here is that intensification of treatment is not helping us. So this is the Kaplan-Meier curves for the DA versus ADE published by the INFOC group. So now, what else can we do? Can we give therapy for a longer duration of time? Okay, so intensification is not helping. Addition of bortezomib, etoposide is not helping. Now, what can we do? So we can give 4 versus 5 cycles. The UK MRC group in the MRC 12 AML 12 trial showed that 5 versus 4 courses did not make a difference. But if you see the COG experience, they felt that the patients, especially the ones who were cytogenetics NOS, those were the ones for whom, if they gave only 4 cycles of chemotherapy, their outcomes were poorer. So now COG will never give 4 cycles of chemotherapy. They will stick to 5 cycles of chemotherapy because they have burned their fingers. They feel that only in the core binding factor leukemias who are MRD negative, those are the only ones where they are able to give, they might give 4 cycles. All other patients, they will go ahead with 5 cycles of chemotherapy. And these are all pediatric experiences. So how else can you intensify treatment? So let's look at the biology of the disease. So if you see in AML, what happens is when you give the chemotherapy, most of the patients, we are using cytarabine, and most of the patients, the blasts, around 8 to 10% of blasts at any given point of time are in the synthesis phase. So cytarabine acts in the synthesis phase, and daunorubicin also acts in the synthesis phase. So what happens is, when you want to attack these cells, you want these cells to come into circulation. So you give a prolonged exposure. So that is why many of the protocols now give, instead of 3+7, they give 3+10, because they want to capture or give prolonged exposure of cytarabine. What else can be done? What we call as the time sequential therapy in AML. So this was what the CCG 2891 American protocol did. What they did was, they gave 4 chemotherapy agents, dexamethasone, cytarabine, thiaguanine, and etoposide, along with daunorubicin. Okay, so the daunorubicin, what they did was, they gave 4 days of chemotherapy, gave a gap of 6 days, and then again, when you felt that the cells are coming into circulation at day 10, you start giving them cytarabine again. And what happened? They saw that there was definitely some improvement in when you intensified the treatment. So disease-free survival at the end of induction of patients with AML was definitely improved. But again, if you want to do this in our setting, we have to see whether that increases toxicity. What you see here in the COG trial, the CCG trial, they found that the disease survival was significantly better. The overall survival was also significantly better, 63 versus 47%. And the 5-year OS was slightly better. So you cannot say that it made a difference. So definitely what they felt was that going forward, we might not have to give 4 agents, but we might give a lesser number of agents and try to bring these patients into remission. So a French group tried to replicate this data, and what they did was they gave chemotherapy for 3 days, and then they did on day 14 they did a marrow and tried to see whether those patients are into remission, and tried to give chemotherapy at that point of time. So what you see here in the arm A, what they did was they gave, irrespective of the blast count, they gave chemotherapy on days 7 to 8 and 8 to 10. Okay, so they tried to give chemotherapy for 3 days, gave a gap, and then gave chemotherapy from day 7 to day 10. So that is how they did one arm. And what they did for the other arm is that day 15 they took a marrow, and on day 15, if they found that there were more than 5% blast, they gave another cycle of Ara-C with amsacrine. Okay, but if they did not have any blast at this point, they continued, and once the marrow recovered, they gave 3 cycles of HiDAC. So what we are comparing here is that patients who got sequential Ara-C, sequential doses of chemotherapy on day 1 to 3 and 7 to 10. On the other hand, you have patients who got 3+7 induction, and only if they had more than 5% blast, they got the chemotherapy on day 14. Rest of them got only 3 cycles of consolidation after count recovery. And what they did was they tried to see whether it was effective in the core binding factor leukemias. So what they saw here was there was no difference absolutely whatsoever. Okay, so intensification of chemotherapy had not helped, and they could not replicate the CCG data. So the cumulative incidence of relapse was also not different, and the overall survival remained the same. So what we tried to do here at TMH, this is our own data, where we tried to give time sequential chemotherapy. So what we did was we gave chemotherapy HiDAC on day 10, where we gave Ara-C at 2 gram per meter square, which was twice a day for 2 days. And this we did irrespective of counts to see whether that improves the outcome. And more of our concern was whether that increases toxicity. So if you see here, we do not have long-term data. The median follow-up time is just 12 months. So we have just analyzed the data and seen that out of the 18, around 44% of the patients are alive, whereas in conventional chemotherapy, where they received 3+7, followed by HiDAC, the patients, around 48% patients are alive. The toxic death was more in the conventional chemotherapy arm, around 32% versus 22%. Now, with the numbers, it is difficult to see whether they are statistically significant. Now, this is counterintuitive, but what we feel retrospectively is that the patients at day 10 who had developed fever did not go on to receive that day 10 HiDAC. That is why probably those are the patients that have brought down or increased the rate of toxic death in these patients. The incidence of refractory disease was similar in the 2 arms, whereas relapse there were just 3 relapses in the HiDAC out of 8 and 1 in conventional chemotherapy. But again, the follow-up is quite short, and that is why it is difficult to see what can be taken from this data. But again, at least we feel that the chemotherapy-related mortality, the infection-related mortality, did not differ in the 2 arms. So when we have long-term data for these patients, we will know whether the time sequential chemotherapy really helps in the pediatric cohort. Now, what is the next step? So next step is we have tried, if you go just stepping back, we have tried to change the daunorubicin, the anthracycline. We have tried to increase the dose. We have tried to add agents. We have tried to change the dose of cytarabine. We have tried to give time sequential chemotherapy, but none of them have actually shown a major difference like you see in the ALL. So we have to study it very sequentially and try to make incremental gains to try to improve outcomes in AML. So that is what we would infer at this point. The next thing is whether maintenance as we gain ALL can be used in AML. So this is a study from the ELAM group where they tried to give IL-2 maintenance for patients after completion of chemotherapy for those who are in complete remission. So here, if you see, the probability of survival was not different between the two arms, and the probability of disease-free survival was certainly a little better in the IL-2 arm as compared to the arm that did not get IL-2. Again, here remember that if patients relapse, those are the patients that go into go in for salvage therapy and then receive a transplant. So that is why many of these trials, it is we can say that the overall survival, we can see that the overall survival remains the same irrespective of if there is a difference in the disease-free survival. Another study, the LAMES group from France, they also tried to do the phase 3 trial where they gave 1.5 years of oral 6-MP and Ara-C in pulses as maintenance therapy. And they found that the overall survival actually decreased for those patients who went on to maintenance. And that was because many of the patients who had a relapse were not able to salvage those patients because those patients were chemo refractory. So addition of maintenance therapy make these patients chemo refractory, and there was no difference in the disease-free survival. So that is why so far the attempts to give maintenance have failed. But we have to see in our own setting where because we cannot intensify treatment, we have to see whether we can do maintenance or whether we can use newer agents to try in maintenance. So this is again an adult study where they used oral azacitidine. And if you see this, they have compared the relapse survival and overall survival between the two arms. And in the adults, they definitely found a difference of 9.9 months between the two arms where the azacitidine maintenance was better. And the relapse survival was also better in the azacitidine arm. So azacitidine is something that we can definitely try for maintenance. But again, you have to remember that the adult biology of the disease might be different from the pediatric biology. And these were used in mostly patients who are more than 60 years of age. So the challenge remains. So we have tried different things and we have tried intensification of therapy, but there has not been a major incremental gain in outcomes for patients with AML. On the other hand, if you see what has happened in our setting, especially, we have seen that the infection complications have increased. Now, this is not because we have changed therapy, but in the post-COVID era, we have definitely seen that the incidence of multi-drug resistant sepsis has improved, has increased. So if you see the toxic death rate before the COVID era was around 12.6%. And after COVID, it has gone up to 23.6%. So we are losing a quarter of the patients to infections. And these are toxic deaths. In induction, we are seeing a mortality of around 17.3%. So you can see there is about a 6% difference. And that 6% is because we are also getting MDR sepsis post-induction, and in the consolidation phase also we are losing patients. So definitely that is a cause of concern, and that is something that if we improve, that will improve our outcomes. So that is something that we need to work on in our setting. Now, when you see why we are failing, because most of the Western world, they are giving prophylactic antibiotics in their trials. So can we use that? It is difficult. You know why? Because we see a lot of gram-negative sepsis, which is multi-drug resistant. So what antibiotic are you going to use? Are you going to use ceftazidime ivapectam for your maintenance? What can we do? Are you going to use colistin? Because if you use meropenem, there are 40% of the patients, based on our experience, those will be resistant to the meropenem. So we have limited choice in this case, and prophylactic antibiotics might not help in our setting, whereas it might be helpful in the Western setting. So again, here we are trying to highlight that the multi-drug resistant gram-negative bacterial sepsis in induction mortality, around 73% of them were multi-drug resistant bacteria. So among the positive cultures, 73% of them had gram-negative multi-drug resistant bacteria. And the toxic deaths, again, in the consolidation were also around 60% of them were because of gram-negative multi-drug resistant bacteria. And if you see the mortality, around 35% of the patients who develop a gram-negative sepsis are we are losing them because of MDR sepsis. So what are these organisms? So Klebsiella in our cohort, this is the antibiogram. Klebsiella was the most common, followed by E. coli, Pseudomonas. So gram negatives again predominate, while gram positives were less. Acinetobacter is something that we see in the ICU. And then we have seen Candidiasis coming up, though it is not a bacteria. Candidiasis is something that we see when we give prolonged antibiotics. Selectively, Candida stays behind in the gut, and that is what causes systemic candidiasis. So that is another major killer that we need to be aware of. So many of us are now using voriconazole prophylaxis or some form of antifungal prophylaxis in our regimens. So again, this is the data where we had 209 patients who are culture positive, of which 80% were gram-negative bacilli, and around 73% of them were basically multi-drug resistant. So apart from bacteria, as I said, Candida is one of the problems, but this is something very familiar that we see. So fungal infections again are a major cause of morbidity in our setting. So we have to deal with this, and I think many of us have used antifungal prophylaxis with good effect. But if you see, many of the patients that present to us at baseline have a lot of fever. It could be disease fever, but they also have a lot of infections, and they have received a lot of antibiotics for a prolonged period of time, and they reach us late. So the period of neutropenia that they have is very long. And when they have this prolonged period of neutropenia, they are at risk of fungal infections. So we started doing baseline non-contrast CT of the chest before starting any chemotherapy. And we felt that there was a substantial number of patients whom, if we gave upfront intensive chemotherapy, we would have lost them to fungal infections as well. So what we try to do is that we try to use upfront metronomic chemotherapy so that we can build up their nutrition, we can give them antifungals and control their fungal disease. If they are colonized with multi-drug resistant bacteria in the gut, then we try to see if we can change the gut flora by giving them probiotics and see whether that changes. Or if some patients who had severe malnutrition, if we can build up their nutrition and bring them to an optimal level where we can give them chemotherapy. And because of that, if you see here, what I'm showing is that overall survival and event-free survival between the patients who received upfront oral metronomic chemotherapy versus those who did not receive, those who went for 3+7 upfront or intensive chemotherapy upfront. As you see here, that the overall survival has not changed, or the overall survival between the two arms is similar. So what we feel is that if those patients were given intensive chemotherapy upfront, their outcomes would certainly be very low, because they would have succumbed to a lot of induction mortality. So by doing this upfront oral metronomic chemotherapy, we are able to bring a lot of patients in a shape fit to receive intensive chemotherapy, and we find this very useful. And that is something that we cannot do a randomized trial, which is very difficult, because if you have upfront fungal infection, it is very difficult to give them upfront intensive chemotherapy. But that is something that we have found useful, and we continue to use it in our setting. Oh, I think I'm going the wrong direction. Okay, so let's come to other challenges. So what are the other challenges that we face when the patient presents to us upfront? So hyperleukocytosis is one of the challenges that we always face, and the incidence of hyperleukocytosis in patients with AML is around 12 to 25%. And we have seen that the early mortality in the literature for these patients with hyperleukocytosis is about 20%. And complications of hyperleukocytosis increase when the WBC count is more than 50,000. Rapid cytoreduction is something that will help, because if your count remains high for a prolonged period of time, then you are at risk of having complications due to hyperleukocytosis. In a meta-analysis by Obera et al., they did not show any benefit of cytoreduction using leukapheresis or hydroxyurea in combination with chemotherapy or hydroxy or chemotherapy alone. So why was that? Because when you see that main challenge for hyperleukocytosis, the complications of hyperleukocytosis are not only because of the blast. Definitely it is the blast and the interaction of the blast with the endothelium. So that is one thing that causes leukostasis, and that leads to complications. So definitely bringing down the count should help, but that has not helped in the past. But why so? So one of the things is leukapheresis does not mitigate this interaction between the blast and the endothelium. So leukapheresis has not found to be useful. Chemotherapy, again, by giving cytarabine, it has not found to be useful. Hydroxyurea works in about 30% of patients where the counts come down to less than 50,000. So it definitely works. But if you see, the cytoreduction is very slow with hydroxyurea. What we have seen is when we gave asparginase in ALL, AML, and CML, when we gave asparginase in a pilot study, about 83% of the patients achieved more than 50% reduction in the count at 72 hours. Okay, and that was because of apoptosis. So the mechanism of apoptosis, it is a controlled cell death, and so we feel that asparginase might be a better agent to to give in hyperleukocytosis in AML as well as other leukemias with high white cell count. So in the pilot study, we felt that 75% of the patients with AML that received asparginase, L-asparginase, their count was less than 50,000 by the end of 72 hours. So currently we are doing a study where we are using L-asparginase for hyperleukocytosis, and we will see whether that benefits. So these are some of the things. Another thing that we always challenge that we face in the supportive care is using GCSF and using nutrition. So whether we give a neutropenic diet or not. So these are supportive care questions that have been tried, and from the study from ADR, there was no difference in neutropenic versus non-neutropenic diet. And the GCSF study, everybody knows that in the BFM 93 trial, when they used GCSF, they found that there was no added advantage, but there was no disadvantage either. So that is something that maybe in our setting, that is a trial that we should try and do. Now, the other question is, if we want to intensify treatment or do something different, which are the patients we choose? How do we choose these patients? So MRD is something that we have to look at and see whether we can stratify these patients based on MRD. Again, cytogenesis is one thing that we definitely need to look at, and MRD. So let's look at MRD. What are the challenges in MRD? So far, MRD has definitely proved useful in ALL. In AML also, MRD is useful. It has emerged as a strong factor to predict outcomes. But we still don't know what is the critical value at which we say that the MRD should be considered as a marker to go ahead with further intensification of chemotherapy. Because even if you are MRD negative, 1/3 of the patients will relapse. So MRD is currently still being used, but we still don't have a clear-cut understanding of how do we do that MRD and how do we use that for treatment intensification. So different trials, different studies, and different groups have tried to see what is the best method to assess MRD, whether it is in the blood versus bone marrow, whether you do flow, whether you do NGS. Another challenge with MRD is that if you do multi-parametric flow, it is very difficult to standardize. The normal blasts of AML look very similar to the AML blasts, and that is why it is difficult to really say whether this is an abnormal blast or not. So that is why we need highly trained professionals to really look at the MRD. And for India, it should not be a challenge because we have a lot of talent, but we need to standardize this across all centers and try to see whether AML MRD can be standardized, and that is something that we have to look for in a clinical trial. But let's look at some of the data. So in AML MRD, there are two ways of looking at it by flow cytometry. One is leukemia-associated immunophenotype versus different from normal. So just let me take a minute to explain what is leukemia-associated phenotype and what is different from normal. So if you see the initial clone of leukemia, leukemic blasts will express certain antigens on their surface. So you want to see if those blasts are still remaining. So you want to see whether there is residual leukemia based on those markers. Okay, but that has not shown to be really effective because AML is quite heterogeneous, and there might be the markers might be downregulated, and there might be different markers that might come up, and that is why you might miss that clone that is still persistent. Whereas there is another way where you look at different from normal, okay, where you just see a normal blast and you see whether there is increased expression of certain antigens on the surface, or there is expression of abnormal antigens on the surface, and see whether that is different from the normal. That is what is called different from normal. So you also have to see whether the MRD is something that can detect the leukemic stem cells, because what happens is you are able to get rid of the leukemic blasts, but the leukemic stem cells are dormant and they are not responding to chemotherapy, and those are the ones that if we can detect, then we can really say we can make our flow MRD more robust. Now, what if we use RT-PCR? So many groups in Europe use RT-PCR, and that is where they have seen that RT-PCR might be helpful. But again, you have to make different libraries for different clones, and AML is a heterogeneous disease. So if you follow FLT3 or if you follow NPM1, those clones might not be present at the time of relapse. So that is why monitoring MRD by RT-PCR is good, but again, it is difficult to predict relapse. So you see RT-PCR, and here I label it as RT-qPCR. So you have to compare it with a housekeeping gene. And this is a study done for core-binding leukemias, where RUNX1T1 and core-binding factor inversion 16 was studied. MRD was more prognostic than diagnostic significance of FLT3 status or KIT mutations in some studies. So basically what they're trying to say here is that MRD, by using these driver mutations, is something that can be used when you use RQ. But when you use FLT3 or anything else as at baseline, that might not be useful. So basically what here they are trying to say is that the MRD emerged as the most prognostic factor because FLT3 status did not matter, or any other high-risk cytogenetic features did not matter. MRD was the most prognostic factor. That is what they have studied in this. And this is the French group trial where they felt that time point 2 at end of induction 2 was what they felt was the most important time point. But again, different groups have tried different things. This is a Chinese study where they say that end of consolidation is most prognostic, where if you are less than 0.02% at end of consolidation 2, your incidence of relapse is going to be less than 20%. But again, there is no point in trying to find out MRD so late, because our entire aim is try to intensify treatment for these patients. So this is the data from the Chinese group where they showed that if your MRD is positive, then you definitely need to go for transplant for these patients, and those are the ones that benefited. So now again, what we want to see whether time point 1 or time point 2 is what is significant. And here we are seeing how the age shows post-induction at time point 1, where there was definitely a difference. You see the P value is 0.05. At time point 2, that is post-induction, the P value is again significant, and end of consolidation also the value is significant. So definitely there's a difference, but we have to design, or we have to take this data into context, whether we are going to intensify or we are not going to intensify. Now they also looked at this in terms of whether MRD helps us for standard risk, intermediate, or high risk. So definitely high risk it helps, intermediate risk there is a difference, and standard risk there is a difference. So again, how do you interpret this in context? So standard risk, there is a difference, but is it and it is statistically significant, but does it help? Because are you going to transplant these patients in first remission? So it is not going to help us, because even if they relapse, we can salvage these patients, standard risk patients, and put them into remission and do a transplant and in second remission. So standard risk is out. High risk, we want to transplant them in first remission. There is definitely a difference, but again, there is a 40% chance of relapse in high risk patients who are MRD negative. So we are left with the intermediate risk, where we feel that that is where we can make a difference, where we can transplant them in first remission. So this is what we infer from this study. So here again, in the same study, they are trying to look at cumulative incidence of relapse based on MRD at time point 1 and time point 2, taking these two together. So here, if you see the cumulative incidence of relapse at when you say time point 1 and time point 2, there is a difference. So MRD, this is MRD negative at time point 1. This is MRD negative at time point MRD positive at time point 1, and MRD negative at time point 2. So if you're MRD positive, definitely it helps. But if you're MRD positive at time point 1 and become MRD negative, there is not much difference. Okay, so MRD at time point 1 was found to be most significant in this, and the most significant difference was in the patients who are MRD negative at time point 1 and time point 2, and those who are MRD positive at time point 1 as well as time point 2, which is quite logical. So again, the COG tried to do this in a little more detail, where this is the schema for them. What they have shown here is that, as I told you, the different from normal versus the patients versus the immunophenotype at diagnosis. So when they did different from normal flow, they found it to be more useful. And here you can see the overall survival of patients who were MRD negative was 73% versus it was 48% for those who were MRD positive. Now, what they want to show here is that 36% of the MRD negative patients not attaining morphological remission have a superior EFS. So what we want to show, what they're trying to show here is that when you do your MRD by morphology versus by flow, the flow was definitely superior, because when you saw, even when you had 15% blasts, even when you had 15% blasts in peripheral blood, about 30% of them were MRD negative. So those are normal blasts. So MRD becomes important at this point in time. So what we are doing here? So we are doing a 16-color flow, and we feel that a 16-color flow might be superior to a 8-color flow. So what we have seen in our experience is that the MRD negative patients definitely did better as compared to MRD positive patients, and this was at time point 1. So PC1 is post cycle 1. It also impacted the overall survival. So now there is a meta-analysis about different ways of doing MRD, and when they analyzed about 81 publications with more than 11,000 patients. Most of the studies had given anthracycline cytarabine-based regimens. It included adults and children, and MRD was done by either multiparametric flow, PCR, or NGS. What they felt that achievement of MRD negativity was associated with a superior disease-free survival and overall survival, irrespective of age, assessment of time point, whether it was end of induction, during consolidation, or after consolidation, whether it was core binding factor versus non-core binding factor, and whether the specimen was blood versus bone marrow. So now, if we look at this, is what they have shown. Ultimately, it shows that MRD is important, okay, but still they are not able to find out what time point. What the same group tried to do is they tried to see whether we need to do a bone marrow at every time point. So they did a bone marrow at day 22 and they compared it with MRD at day 8. So here we are comparing of patients who are bone marrow positive and blood positive, and definitely they did worse. Okay, we are trying to identify these patients early. Those who are bone marrow negative but blood positive did better. So what we are trying to, and then those who are bone marrow negative and blood negative did similar. Okay, so that is why our bone marrow negativity is important. Those who are bone marrow positive and blood negative, also they had not much difference. Okay, so event-free survival for bone marrow MRD positive patients was definitely different. So if you are bone marrow positive and blood positive, your outcomes are poorer. But if you are bone marrow, okay, so this is something different. So let's skip this. Okay, so challenges again remain that response assessment MRD is not standardized. Risk stratification, again we see that MRD might not be sufficient because you have core binding factor, KIT, and different subgroups. Okay. Okay. So now, what is the challenge? Just give me 1 second. Okay, some mess up in the slides. Okay, so basically, now we have seen that MRD is important. Okay, and it might most useful in the intermediate risk subgroup. So now the question is, if they are MRD positive, what do we do next? And I know there are many transplanters in the group, and we will see their contribution is very helpful to us. So role of allo-HCT in intermediate risk AML in less than 60 years of age. So overall survival actually in this analysis, they showed that the consolidation chemotherapy versus allo-HCT did not make a difference, but disease-free survival was definitely better when you did allo-HCT. So this was done in a German group where they had 81 men and 62 women. Mean age was 51 years in 16 hospitals. Okay, 143 patients were randomized. And this is for the intermediate risk group. Now, we generally believe that the intermediate risk group should benefit, but in this, they have shown that there was no significant difference between the chemo consultation versus allogenic hematopoietic stem cell transplant in the intermediate risk group. And again, each trial, each subgroup might be different. So here, so here, because they had not stratified these patients properly, we feel that this might be something that we need to look at, because many other groups had looked at intermediate risk patients who benefited from transplant. Now, allo-HCT is definitely important, but as we have seen, standard risk we want to transplant in CR2, intermediate risk in CR1, and high risk in CR1. And the intermediate risk ones who are MRD positive at time point 2 are the ones that you should go for transplant. Now, how does transplant work? Basically, transplant is using immunotherapy. So you are using an immune response from a patient to from a healthy volunteer or a healthy donor to take care of the leukemia. So it was found that the NK cells are the most important effector cells in transplant. So the NK cells work by clear ligand mismatch and identification of non-self. So it was shown by Ruggeri et al. Initially, where they did T-cell depleted transplants. Those who had and clear ligand mismatch, 0% of them relapsed. So that is when NK cells were identified as the most effective cells in AML. And this was studied further. And there have been different trials to try to give NK cells in AML. So this is a phase 1 trial that was done at St. Jude, where they felt in the pilot study, 10 patients received NK cells and they were followed up for a period of time. And those patients definitely did better. Whereas when they did a phase 2 trial, they did not find a major difference between the two. The reason probably was that they did not select their patients properly. And the other thing is that they did not select specific NK cells. The NK cells that were given were not expanded, or they were not, they did not last for a longer duration of time. The advantages of NK cells are that they do not cause any GVHD. So that is the best cell that they can use, because they can cause GVL without causing GVHD. So now we need to see whether we can expand those cells, because we want to give more numbers, or whether we can keep them alive for a long duration of time, as we see in CAR T cells, where persistence of the CAR T has helped in trying to bring better remission rates and prolonged remission in ALL. So what has been done is we have tried to incubate the NK cells with different cytokines and try to give them a memory-like phenotype. So memory-like cells, they expand after seeing the target. Okay, so that is the principle behind your vaccines, where these cells remain in the circulation in a very low numbers, but when they see that antigen, they will proliferate. So that is called memory. So we try to make memory-like NK cells and try to give them into the patient. This is a phase 1 trial, and this showed that phase 1, phase 2 trial. This showed that memory-like NK cells lasted longer, and around 40% of patients who had relapsed refractory AML, chemo-refractory AML, went into remission, and they were consolidated with the transplant. So this is something that we are trying to do at our center, where we are trying to make memory-like NK cells, and soon we expect to go in a phase 1 trial. But then after all this, we are giving the same chemotherapy, and that is where our opportunities lie, because we are treating AML as one block, and it is not. So that is why we have to treat each AML differently. So NGS diagnosis is NGS at diagnosis might become something that is very important in AML. Not all centers are able to do it, but that is where we will go, because as you see in ALL, we have tried to use dasatinib for pH positive and pH like ALLs or tyrosine kinase inhibitors. Similarly, we can try to see whether they are useful in AML. And there are several studies that have shown that it might be useful. Again, for us, MLL is a major chunk that we see in pediatric AMLs. And there is currently an ongoing trial where using menin inhibitors that might be useful. The FLT3 is again a tyrosine kinase. So FLT3 inhibitors is something that we can inhibit and see whether we can improve outcomes. So the opportunity for us going forward is that we use a chemotherapy backbone by adding these targeted inhibitors or targeted therapy, and try to use harvest the immunotherapy for our patients like NK cells. So again, if you see the MLL subgroup, again, this will come up in the discussion where whether 9/11 should be a good risk or intermediate risk or high risk. So you see here that MLL translocated children, AMLs, have again multiple translocations. There are so many partners of the MLL gene. and each partner does differently. So that is why, again, you have to see whether there is a difference. So what I'm trying to emphasize here is that AML is a heterogeneous disease, and we need to tackle it as a heterogeneous disease, not give a blanket therapy. So that is where our opportunities lie, and that is where we can use the targeted therapies. So coming to MLL again, the menin inhibitors are the ones that might help, because what happens is when you give with the MLL translocated genes, there is block in differentiation and there is a proliferative advantage. So if you use menin inhibitors, you can block the interaction of MLL with the menin, and that will help the cell differentiation and reduce its proliferative advantage. And these cells will be more amenable to chemotherapy, and they will differentiate. So that will be one way of trying to get these patients into remission. Again, as we are see the core binding factors, which we see as a major chunk, are still not homogeneous. There are KIT mutations, WT mutations, and that is where again we can see whether we can add inhibitors like dasatinib for the patients with KIT mutations, where we can improve their survival on a chemotherapy backbone. Again, KIT mutations again are heterogeneous, where exon 8 and exon 17 make a difference, where exon 17 is worse. So this is data from our center, where we have seen difference between cumulative incidence of relapse for KIT positive versus KIT negative mutations. The survival it is tending towards statistical significance. So here is a paper from Turlock et al. And here you see that addition of gemtuzumab ozogomycin for core binding factors with KIT mutations definitely helped. So their outcome was superior. So that is how we need to design our trials. And we did not speak a lot about gemtuzumab ozogomycin, but that is where the AML 0531 trial showed actually no benefit. But there are several trials that showed that gemtuzumab ozogomycin might benefit, and that is something that we are trying to use upfront in many of the trials. Last but not the least is venetoclax. So what we are trying to do is try to kill the cells, okay? But these cells are still surviving, because there are ways for these cells to escape the cytotoxicity. So they are not undergoing apoptosis. Venetoclax is something that we can use to induce apoptosis in these cells, and there are several trials in the adult experience where they have shown that adding venetoclax to their chemotherapy backbone has improved outcomes. So we have pediatric data, phase 2 data from St. Jude's, where venetoclax definitely seemed to have a better outcome when combined with chemotherapy. It was not toxic, and that is where we will see that the future trials in AML, we have opportunities to try and improve outcomes. So I think in the interest of time, I think we will go for discussions rather than going on further. We do have some data from on venetoclax in our setting, but that data is not mature enough. But we feel that around 50% of the patients who receive venetoclax in de novo AML, along with azacitidine, are able. These children were able to achieve a remission. So that is something that we will see going forward. With this, I thank you for your patient hearing, and we will go for discussion.
Thank you, Dr. Chetan Damne sir, for that wonderful overview on pediatric acute myeloid leukemia. It was fantastic. And we'll start our question answer sessions with our discussants. So I request all our discussants to please put your raise hand so that we can start our Q&A session. In the meanwhile, I'll take some of the questions from the audience. Dr. Sujata Sharma wants to have your opinion regarding ADE regimen for pediatric patients. Can you please elaborate the same which you talked about your ADE regimen for pediatric patients?
So ADE versus AD has been tested in the UK MRC as well as the trial from Inform, and they found that there was no difference in outcome between the two trials. The toxicity was also the same, but it has not improved the disease-free survival as well as the overall survival. So adding etoposide has not helped. So I feel that just 2 drugs should be what we should use at this point in time.
Thank you, sir. Dr. Rajat Bhattacharya, question, please.
Yeah, Chetan, always a pleasure to hear you speaking. Chetan, I've got two questions. So one was about the venetoclax, and do you think BH3 profiling will be important to prognosticate which patients are going to respond to venetoclax? That's one thing. And second thing, where do you see the BiTEs and TRITEs and CAR-Ts coming in? Knowing that in ALL they're really replacing some of the intensive chemotherapies and making treatment much more less toxic, which is a problem for pediatric AML therapy. So these are the 2 questions I have.
Right. So Rajat, as you said, pleasure to meet you likewise. So basically, BH3 profiling is something that I think will come along the way, and that will be certainly helpful for us. What we need to do more is that we have to see, along with BH3 profiling, we have to see whether we have other targets along with it. So what we have seen that the FLT3 ITD patients, when we give venetoclax with azacitidine and midostaurin, those patients have definitely done better. Without chemotherapy, we are able to achieve remission in about we have 5 out of 7 patients who have achieved a remission. So just BH3 profiling will definitely help, but we also have to see whether any additional inhibitors can be used along with the ven as a backbone, and that is where we have opportunities to proceed further. But BH3 profiling will be something that will come when we get access to venetoclax. So right now, access to venetoclax is limited, and we have to look at it in a controlled study rather than many people are using it without a proper study. But that is the best we can do for our patients. So BH3 profiling will come. The other question you are saying is the BiTEs and the TRITEs. So blinatumomab has certainly helped. So we have gemtuzumab ozogamicin, which is again a monoclonal antibody against CD33. It has shown benefit across the groups, but it was small incremental benefit. But we need to use it a little better. So many groups are using it. So we just need to know how to use it. But I feel that is a very important drug that will come into use. In AML, you see that T cells are robust, so maybe monoclonal antibodies will help, but the T cells do not act via antibody-mediated cytotoxicity. That is where the NK cells help. Okay, the PDL1s on the AML blast is upregulated, but we still don't know whether the T cells are the ones that will be most effective taking care of the AML blast. So that is something that we need to study further. CAR T cells AML have not found to be very useful at the moment. The reason being there's a lot of toxicity. And if you have persistence of the CAR T cells, then your normal myeloid cells are not going to recover. We can get away with B cells, but we cannot get away with neutrophils. And that is where I think we have a major problem. So we have to use NK CARs probably, and that is exactly how the GO is acting. So anti-CD33, anti-KIT, anti-CD117. These are the targets that definitely will be studied in the future. But with the limitation of intensification of chemotherapy, I think that is something that will come, and it will soon be into trials, what I feel.
Thank you, Dr. Rajat. Another question, Dr. Gyanamani Sengutan, your question, please.
Thank you, sir, for an elaborate talk. So my question is, most of the current contemporary protocols advise treatment based on cytogenetics and molecular features at diagnosis and the MRD responses. But in low middle income countries, most of the times we are not able to give targeted therapies or transplant. So in such a, and most we end up doing one size fit all approach of AD followed by HIDEC. So in such a situation, do you still recommend the complete cytogenetic and molecular workup? Is it really worth doing in the absence of prospect of transplant?
I think that is a very good question because you are not using it. But I think now there is good data to try and use some of the inhibitors. So that until we have access to those, maybe we can skip that. But the other thing is that we should have an AML registry where we collect all this data so that we know what is the need for our area. How many of our, what is the molecular profile of our patients. So that is where it will be useful. But I agree, if your patient is not affording and you're not going to change management based on your cytogenetics and molecular, it is okay not to do. Provided you're saying that your patients do not have access to transplant. If your patients have access to transplant, then definitely that molecular, cytogenetic data is going to be useful for you because you are going to decide which patients go to transplant in first remission. So just to recap, if you have access to transplant, then definitely you should do at least the molecular, at least the cytogenetics. But if you don't have access to transplant, then it is okay to skip in a patient that does not afford. Okay.
Thank you, Dr. Gnanamani. Dr. Juisha, your question, please.
Yeah, hi, sir. So good to see you. It was a really nice talk. I enjoyed it. I have two questions. First is, what is your experience as you showed regarding the KIT mutations, as you showed the TMH data in ALL? Like, how are you all managing it? What TKIs you all are using? And how is it like? Are you giving it on the chemotherapy backbone? Is there a maintenance? And how are you monitoring, like MRD along with, or like PHLL? Are you using the monitoring the mutation, KIT mutation as well? And the second question is, as you showed that infection-related mortality, that is the biggest problem in our country, especially when it comes to ALL induction. So like we have preemptive antifungal prophylaxis, is there any data or guidelines suggesting antibiotic prophylaxis like we have quinolones for high-risk ALL?
Right. So thanks, Jui. So Jui, your first question was about the KIT mutation. So currently, we have definitely identified that the KIT does worse than the others, and that is where we are trying to use dasatinib for these patients. We use them. We use dasatinib at the end of chemotherapy from day 7 until count recovery, and we have done a few patients so far, but we need to accrue data on that to see whether that increases your mortality, increases risk of infections, and whether it is really going to help. So that is quite in the preliminary stage, but that is how we are using the dasatinib for KIT mutated AMLs. To prevent these infections. So again, our antibiotic sensitivity pattern is something that we really need to look at, and we have seen that the antibiograms from each institute, even the ICU and the ward, might differ. So that is why it is very difficult to prescribe one sort of antibiotic prophylaxis, especially in the setting of multi-drug resistant bacterial sepsis, because you are selecting out for the resistant bacteria. So even in the St. Jude trial, they felt that patients who received vancomycin, there was increased risk of VRE. So that is something that we don't want to embark upon given our current scenario of MDR, because we have seen that at 40% of the patients are MDR positive at diagnosis. So that is something that we need to really be very cautious about. It should be done in the context of a clinical trial where we really know we have an interim analysis, we have stoppage rules where we try to do that and see whether that is going to add any benefit.
Thank you. Thank you.
Thank you, Dr. Juisha. Dr. Ruchi, your question, please.
Yeah. So thank you very much, sir, for such an elaborate and wonderful talk. I have a couple of questions. One is it's just related to our day-to-day treatment. So say if there is a patient who is FLT3 positive and is in CR2 after the first cycle of consolidation, but hasn't got a mass sibling donor or the mud for transplant. So what would be your take? Would we like because he is now in MRD negative, would we continue with the CR2 or because it's a high risk?
Dr. Ruchi, we could not hear your question. Can you please repeat your question? Your voice was
So
broken.
can you hear me now, sir?
Yes, now we can hear.
So I got the point where you're saying that these are FLT3 IT patients who are now in CR1 and
After the first consolidation, yeah.
Do not have access. Yeah. So you have or you do not have access to transplant?
So we have the access, but we say we haven't got a match sibling donor or the mud availability. In that case, because considering the high risk of mortality with the unrelated donors, and because the child is in remission, but still, would we think of going with the haplo transplant or something like that?
Yeah, so I would actually put that question to the transplanters because definitely FLT3, what we have seen is that in our cohort for the last 5 years, we have very few survivors of FLT3 ITD. So most of them have gone ahead and relapsed. So if they have achieved the CR, I would go ahead and transplant them. But it depends on the transplant related mortality that you have and the affordability. So I would like to ask the transplanters here whether you would transplant such a patient. For me, I would.
So if anybody has any answer for this?
I can answer.
Yes.
So once Brenda Gibson told me that in AML, your cytogenetic and molecular genetics trumps MRD. So FLT3 now is a high risk feature, right? The high risk of relapse and things. So these patients should be transplanted. And I would say I would rather do a haplotransplant on this kid. But if you use the selective T cell depletion, which as Chetan has said, uses the NK cells to the advantage. Yes, so in my previous center, these sort of patients will just go to a consideration haplotransplant using the selective T cell depletion and use the NK alloreactivity. So answer is yes for a haplotransplant. The only issue with the PTCY transplant is that you kill the NK cells by giving the cyclophosphamide. So immediate NK alloreactivity is not there. But yes, it will develop from the stem cells, and even gamma delta T cells have some KIR receptors. So they may be it's still worth doing if you're doing a PTCY. But ideally, yes, you should go for a haplotransplant for this kid. That will be my take. Thank you.
Okay, thank you, sir. And just one more question, sir. The other is that how effectively can we use itraconazole in place of voriconazole for antifungal prophylaxis if the voriconazole levels are not easy to be done?
So itraconazole in place of voriconazole.
So the question is whether itraconazole can be used. So basically, I have used itraconazole when I was previously in Singapore, and that was the go-to antifungal for us at that time, and we found that it was pretty effective. So I think it should be fine. So you can use itraconazole.
Thank you, sir.
Thank you, Dr. Ruchi. Dr. Balaji, your question, please.
Good afternoon, sir. Thanks very much for the wonderful talk. I have a couple of quick questions. You have shown a data on the end of consolidation MRD. I think it's a Chinese study. In your practice, what is your recommendation for end of consolidation MRD, sir? And if at all, if it is positive, do you go for a transplant with that data?
Yeah, so again, AML is not that straightforward because if end of consolidation MRD is positive for core binding factor leukemia, I would still wait, try to put him into remission because around 40% of them will still maintain a remission. So That is what the AML 0531 study showed. Okay. So if it's core binding factor, I would not transplant. If it is intermediate risk or high risk cytogenetics, then definitely I would go ahead, try to achieve a remission and then go for transplant. But I would transplant when the patient is in complete remission, MRD negative remission.
And one more thing is you shared a few details on the LAS pilot study. Do you find any survival benefit in that pilot study? And can you elaborate more on that, whether it is for TLS related things or you have focused more on the complications because of leukostasis?
The asparaginase study, you're asking whether there is any preliminary data for that to use in hyperleukocytosis. So that data, the accrual has been very slow on the trial, but we will try to do an interim analysis pretty soon. But at the moment, what we feel is from experience, this is very anecdotal experience, and we feel that the asparaginase definitely brings down the counts much faster as compared to hydroxyurea and without any complications. But again, until I have the data, I will not recommend anything at this point. This is just something that we need to analyze further before we give any recommendation.
Thank you, sir. Thank you.
Thank you, Dr. Balaji. Dr. Vinay, your question, please.
Good afternoon, Dr. Chetan. It was a very nice talk, a lot of evidence-backed slides. My questions, 3 questions. So one is, instead of Dono, if we use mitosantron along with Arasi, what would be your take or what is the evidence for long-term cardiotoxicity in kids? And if that is there, is it worth changing our protocols to mitosantron, cytarabine? That is first. Second question is, cytarabine, can we use like what is the usual way in induction? Does it need to be given as an infusion to improve the efficacy, or commonly we use it as bolus doses in the induction, 100 mg per meter square twice a day? Which one do you recommend? Third is your center's experience on the duration of venetoclax that we can give. Mostly I have had experience while working with my adult colleague where giving venetoclax for more than 14 days makes the patient very neutropenic. We'll have to stop and things. But what has been the experience in Tata? How long have we been able to give venetoclax in induction in the small pilot that you have seen? Thank you.
Right. So let me answer the venetoclax question first, and then we'll come back to the other 2 questions. So the venetoclax definitely, as you have seen, and we have also seen that if you give venetoclax for a prolonged period of time, more than 14 days, it definitely leads to prolonged neutropenia, thrombocytopenia, and anemia. The thrombocytopenia is a major side effect of venetoclax. So more and more, we are trying to use it for a shorter duration of time. We have not used it in induction in combination with chemotherapy yet. We have only used venetoclax with azacitidine as a window, and we have given 1 or 2 cycles before we start intensive chemotherapy. So when we use that, we have initially given it for 28 days, and now we are cutting it down. And so far, we feel that a shorter duration would be helpful. Whether it is 14 days or 21 days is something that we need to look at. And we will have to pick up from the adult experience to see whether that helps. But definitely, 14 days is something that we are tending towards at this point in time. So can you just go back to the first and second question again?
Cytarabine as infusion.
So cytarabine, again, see, basically cytarabine, if you are giving once a day, then in induction, that is not enough. Because you want the cytarabine half-life is around 4 to 5 hours. You want prolonged exposure to cytarabine. So either you do 100 milligram per meter square over as a continuous infusion for 7 days or 10 days, or if you are giving it as a bolus, then I would give it twice a day. So 100 milligram per meter square twice a day is what I would recommend for cytarabine if you are giving it as a bolus during the course of induction.
Thank you. So any other question, Dr. Vinay?
Yeah, he had one more question.
So what was the third question, Dr. Vinay?
Yeah, the mitosantron as the anthracycline in induction.
Mitosantron, so when they when the COG tried to look at the effects of anthracyclines and they tried to look at the cardiotoxicity, they had not many patients who had received mitoxantrone in the COG studies. Mitoxantrone has been used mostly by the Europeans, but there is no such data to definitely show that the cardiotoxicity due to mitoxantrone is higher. In the JAMA paper that has looked at equivalent doses of mitoxantrone with doxorubicin, definitely mitoxantrone is 10 times more toxic than the doxorubicin. So it has more cardiotoxicity. That is what we know. The doses that we have used, other than the cardiotoxicity, when we have used mitoxantrone in ALL induction for a relapse patients, we found that there is a lot of infection-related toxicity. So other than the cardiotoxicity, we are more worried about the infection-related toxicity for mitoxantrone, and so we try to use it sparingly. We are trying to take away the mitoxantrone for our ALL trials at least, and we are trying to stay away from it because of the toxicity. The cardiotoxicity, I don't have clear data at the moment to tell you whether there is any significance of using mitoxantrone and the long-term side effects. That is it.
Thank you, Dr. Vinay.
Thank you, sir.
Thanks a lot. Dr. Sunil, your question, please.
Nice presentation, Dr. Chetan. So I have two questions. So if you have a AML patient with translocation 821 and you have done the molecular and the molecular is showing AXL1 positive. So this kind because AXL1 molecular, it is high risk thing, and 821 is a good risk AML. So with this context, whether if the MRD is negative or if the MRD is positive, whether you going to transplant this patient or just treat with the chemotherapy. Second question is what metronomic chemotherapy you are using when you are not able to give 7+3, whether you are using any experience means azavenatoclax, like we are managing adult patient also. So venetoclax we are using 21 days. Initially we are using 28 days, and now we are fine with this data 21 days. It is helpful in achieving the remission and having minimal toxicity. So the take on that metronomic, whether you change whatever your current regimen to azavenatoclax or just an azacitidine venetoclax.
Right. So very good questions. So basically, again, in core binding factor, there are many mutations that come in. ASXL1 generally is seen mostly in adults. Pediatric, we have very little ASXL1 that we see in our molecular profiles. So not much data on that. But again, as a general rule for core binding factors, we would not transplant in first remission. We would transplant in second remission for those patients. Then your second question was about Ven-Aza versus metronomic chemotherapy. So actually access to Ven is a problem, but when we have used Ven-Aza for patients, we have seen that if we use 28 days, there is still a risk of developing neutropenia, thrombocytopenia, infections. Okay, but majority of the patients have done okay, but that risk exists. Okay, so a shorter duration as you're using, or maybe even shorter, can be used as a bridge to intensive chemotherapy. So whenever, if you have access and if you are very comfortable using it, that is one thing that I would definitely use. But if you don't have access, we have seen equally good results with the 6-MP etoposide that we are using. So there we see at the end of this 1 or 2 cycles, those patients are considered independent. Their marrow has recovered partially, and they can go ahead with receiving intensive chemotherapy. And as you saw before, that those patients, their outcomes were not different, even though they had these high-risk features. Their outcomes were not different from those who received 3+7 upfront or intensive chemotherapy upfront. So right now, unless we have a head-to-head comparison, it is difficult to say which one is better. But both of them we feel are effective. We feel around 50% of them went into MRD remission. So that might be an advantage going further.
Okay, so one last question. What is the take over for this intermediate dose cytarabine versus HiDAC? because most of the adult data, it is they are now switching from HiDAC to INDEC for the intermediate and high risk patient, and good risk they are continuing with HiDAC. So, is there any data in the pediatrics for the INDEC?
So for pediatrics, again, that is a question that is very difficult to answer because there are data mostly in the adults. The data is slightly conflicting. So it is very difficult to give a prescriptive answer for that. But the data from pediatrics where they have used cytarabine in induction from the AML-02 trial, they felt that there was no major difference. And in fact, there was increased risk of fungal infections from the AML-02 trial. Okay. Giving intermediate risk HiDAC, if you see, we are trying to intensify on one end by giving fludarabine or cytarabine, fludarabine or fludarabine or 2-CDA, cladarabine, okay, to try and see whether we can incorporate more ARA-CTP into the DNA so that you have better cell kill. So if you are using it like that, then maybe we can use an intermediate dose, or in combination with venetoclax, maybe a lower dose might be something that we can see in the future. There is wherein we have the opportunities to explore. But at the moment, 3 gram per meter square is what I would use for our consolidations.
Thank you. Thank you, Dr. Sunil. We have some questions from the audience. Dr. Sujata Sharma has raised a question that a patient of AML M3 was to be taken for med sibling transplant, but had retroorbital sarcoma, which was related and then was taken for transplant. But patient relapsed very soon. So question is, was MRD negativity before transplant was beneficial? And second, was sarcoma a signaling of not a good prognostic marker, or any other mode of treatment can be tried for this patient?
So I think this is quite a unique case. So it will be, there'll be a mixed opinion on this. But again, in the presence of a sarcoma, if and this was myeloid sarcoma, or it's a myeloid sarcoma, right?
Myeloid sarcoma.
So in myeloid sarcoma, I would definitely, if there is a myeloid sarcoma, I want this patient to be in remission before I transplant. Okay, because AML transplant I want to do in complete remission. Most of the patients, when they respond to systemically, their myeloid sarcoma also responds. What we have seen is very few patients have, we do an MRI to see whether there is any evidence of sarcoma at the end of therapy before we say that this patient needs the radiation or not. So we have found very few patients who have sort of residual mass. Those patients we are given radiation. So in your case, if you are going to go for transplant, I would radiate, bring that patient into complete remission before going for transplant.
Patient was radiated before the transplant, and MRD was negative before the transplant. That is what she has said. So the question is basically whether the myeloid sarcoma can be a bad prognostic marker, why the patient relapsed very fast after that?
Not really. So there are so many myeloid sarcomas, and again in acute myeloid leukemia also we see that there is a chance of having myeloid sarcoma. Extramedullary disease in AML is a known fact, but we do not do anything extra out of the way to treat the extramedullary disease again unless it is persisting. So I don't think so. You could have done anything differently for this patient. You did the right thing. Unfortunately, this patient had to relapse.
Thank you, sir. Another question is from Dr. Bishwa Prakash. Any phase 3 trial regarding pediatric trial on, as you already answered, pediatric on midostaurin in AML with FLT3 ITD? And what's your experience regarding the midostaurin in AML? If yes, what dose would you like to give?
Yeah, so midostaurin, we are using, the advantage of midostaurin is that it acts against TKD mutation as well as ITD. Okay, so that is something that we are using, but the data is still to mature. And whether it has a benefit in overall survival, it might have some benefit in disease-free survival, whether it has benefit in overall survival, and whether we can use it as a maintenance therapy for patients. So that is something that we need to answer yet. So we are using, I'll have to look up the dose, but we are using midostaurin for our patients, and we'll have to see how that helps in the long run. What we have seen is that in the FLT3 ITDs, we give venasa, as I mentioned earlier, venasa along with midostaurin, we were able to bring many of our patients, about 5 out of 7 patients, into complete MRD remission. Okay, so FLT3 ITD, again, the problem is not about bringing them into remission. The early relapses is what matters. So we have to learn how to use that, and that is something I think we still don't know at the moment. Anybody else would like to answer that question?
Rajat is there.
Yes, we use the same approach. I would say use gilteritinib, the triple therapy. But yes, triple therapy is important to bring this under. But at least one kid who didn't respond to conventional chemotherapy, then FLAG-IDA, and then responded to the triple therapy, and then managed to go to transplant. So yes, triple therapy, but I haven't used midostaurin. We have used gilteritinib. But you have to use the second generation, not the sorafenib is the first generation. And what Chetan has said is absolutely correct. So move on to the higher generation, second generation FLT3 inhibitors. Yep.
Thank you, Dr. Rajat. Dr. Mona Vijay has a question. Can we use azacitidine plus sorafenib in unfit relapse AML FLTG positive pediatric patient? Your experience regarding the sorafenib toxicity in pediatrics?
So I think sorafenib can be used. We have been using sorafenib for our FLT3s for a while. So getting them into remission is fine, but we need to give a prolonged maintenance. That is what we need to look at. For a patient with relapse AML FLT3, definitely when aza plus sorafenib is something, if that is what you have access to, is what I would use to try to bring this patient into remission before I go for a transplant.
Thank you, sir. Another question from Dr. Mona Vijay. Are you sending NGS-based panel routinely for all the patients of AML pediatric? NGS panel.
Yes, I think that is important. We have access to it. Yeah, we have access to it. So I think NGS should be done for those who access and those who can afford, because in addition to being a treatment center for all the patients, we also wear an academic hat. So we definitely would like to do the NGS, like FLT3s, KIT mutations. These are some things which we'll know only when we do the NGS. The type of translocation that you have with MLL to stratify whether these patients need a transplant in first remission, or maybe only if they are MRD positive. So all those treatment stages will come when you have the molecular data. So if you have access to it, you should definitely do it. But if you're not going to act on that data, then as we mentioned earlier, then I would not force you to do the molecular studies.
Thank you, sir. Another question from Dr. Balaji. What is your experience of adding upfront etoposide for a patient with AML with myeloid sarcoma? Any evidence for that?
See, etoposide has anti-activity against AML. But as a single agent, using etoposide is not what I would do. The response criteria, when the initial studies were done, about 40% of the patients, or 40% of them, when the studies were done in mice, 40% of them responded. So as a single agent, I would definitely not use. But we are using it in the oral metronomic chemotherapy that we give upfront, and we have found it to be very useful. We are also using it for maintenance. But upfront oral metronomic chemotherapy with 6-MP and etoposide, definitely we find that it is useful. Even in case of extramedullary, shown to be of benefit. We have also used it for relapsed patients whom we are palliating, and they also remain in remission for a prolonged duration of time. For myeloid.
Thank you. Thank you, sir. Another question from Dr. Silky Jain. What are your flow MRD cutoffs that we use for at the end of induction 1 as well as induction 2 to intensify the therapy?
Right. So again, that is a study in progress. So currently we are able to achieve high level MRD, but 3 log reduction is what has been shown in many of the studies, and MRD of 0.1% is what everybody use as a cutoff for AML studies at the moment. Okay. The time point 1 versus time point 2 question still haunts us, because there are no clear-cut answers, and different groups are using different things. So it is very difficult to recommend one particular cutoff. For us, what I have shown the data, even at time point 1, MRD positivity with the 16 color flow was statistically significantly different. So that is what is the cutoff that we are using at the moment.
On the same question, Dr. Shivani Patel has also asked the question: do you check or recommend end of treatment MRD? And if yes, how do you act on it?
So, so just to complete the first one, we found that there was a difference. But for again, to transplant, if the patient is core binding factor, coming to the same point, we will still go ahead and not transplant in first remission. The MRD at time point 2 is what we use for transplant. So I said that though it is important, the MRD time point 1, the MRD at time point 2 is one that is more important for us to decide the transplant versus no transplant decisions in the intermediate risk cohort. Now, the question was, can you just repeat the question?
Do you check or recommend end of treatment MRD? And
end of treatment, yes. So end of treatment MRD, basically, we have been doing it for some of our patients, and we have stopped that practice. But definitely, end of treatment MRD, we have found some of them are MRD negative again. Not do it as a clinical trial.
So we just lost you, sir. Can you please repeat, sir?
Yeah, is it better now?
Yeah, we could not hear you. Can you please repeat, sir, because there was some network problem.
Yeah. So basically, the question is whether you do end of therapy MRD.
Yeah.
So we have been doing it for a while for our patients, but when they were very low MRD positive, we did not know how to act on that. So we have been following up those patients. Some of them became MRD negative after being MRD positive. So that is why we are tending towards stopping that practice. But I think the different trials have shown that if you detect MRD earlier and try to act on it earlier, then definitely it helps. So I would not recommend for or against it, but if you have the capacity to act on it, then serial MRDs will give a lead time advantage to start the salvage therapy and take them for transplant.
Thank you, sir. Dr. Silkijit, do you have a question? You raised your hand.
Yeah, so I would like to ask one question. Thank you so much, Dr. Chetan, for that very focused talk. And so we all know that in India, we encounter a lot of induction mortality due to infections. Do you see a role of fecal microbiota transplant in that respect to prevent the multi-drug resistant infections that we see?
Right. So I think there might be a role for it. Again, unless there is clear-cut evidence to show that it is beneficial, we will have difficulties recommend anything. But at this time, I think that is one way of trying to mitigate the MDR sepsis that we have. Okay. So definitely, I think that is something that we look forward to and see if that is going to help. So that definitely it will have a role in the future. That's what I feel. But we need data.
Thanks.
Thank you. Thank you, Dr. Silky. Another question has come up from Dr. Mona Vijayan. What is the median days of neutropenia which you encounter with ESA 14 days? When ESA plus 14 days of when?
When I don't have really hard data to tell you anything at this point, but when we used it for 28 days, our count recovery was around day 35 to 40, some of them in day 50 days, 28 days. Now we are using it for 14 days, and we find that duration has definitely reduced, but I don't have a fixed number for you. It is definitely less when we use it for 14 days.
Thank you. So any other discussion has any question for Dr. Chetan Damne, sir? I've finished all the questions from the audience. So anybody else, any advice, comment, any questions for him? So there are no more raised signs, and I've finished all the questions from the audience. So thank you so much for joining us. What a fabulous and fantastic, wonderful lecture. First of all, and second thing, what a wonderful discussion. You answered all our questions, solved so many doubts of us so patiently. Thank you for that, for being over here today, this Sunday morning for us, sir. And it was always very, very well privileged for you to have you on board, sir. Fantastic lecture, awesome, wonderful lecture, and what a wonderful discussion. Thank you so much for being
My
with us.
pleasure. My pleasure. Thanks, everyone.
And I now hand over to Zydus, Mr. Sumit Madan, for the final vote of thanks.
So, thank you, Dr. Chetan, for sparing your valuable time. It was a wonderful presentation, and I think you have given a 360-degree view of all the challenges and opportunities that are there in the management of pediatric AML. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Vinay Bora, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them as well. Thank you so much, everybody, and have a wonderful Sunday.
Thank you.
Thank you.